Well, currently the most commonly used drug for polycythemia vera, because it's widely approved in this indication, is hydroxyurea. Although it's a good drug with good efficacy and good tolerance, we still have about 20 to 25% of patients who experience resistance after a while, so the disease reoccurs, or intolerance, mainly some cutaneous toxicities with leg ulcers, etc. So there's a clear need for those patients who have failed to this treatment or do not tolerate it, and it has also been shown that intolerance or resistance to the drug is an indicator of a poorer outcome after that. So we clearly needed drugs for second-line therapy in these patients. In PV, almost virtually all patients have a mutation in the kinase named JAK2. That is the JAK2 V617F mutation that induces proliferation of hematopoietic cells and increase in red blood cells, mostly in polycythemia vera. Ruxolitinib is an inhibitor of this JAK2 kinase, so it was logical to propose this treatment in these patients with a high activity of JAK2, and in fact it worked in vitro in animal models, and then we had the first trials in patients with MPN with ruxolitinib showing that indeed it was able to block this hyper activity of the JAK2 kinase and the hyperproliferation of cells. Ruxolitinib was tested in a large randomized trial called the RESPONSE trial that compared ruxolitinib to best available therapy in patients with PV who were resistant or intolerant of hydroxyurea. And indeed, this study proved that ruxolitinib was able to induce very nice responses in those patients who were resistant to the current drug, and especially in terms of control of the hematocrit in these patients. 60% of patients on ruxolitinib achieved the target, that was maintaining the hematocrit below 45% without phlebotomy, compared to about 20% in the best available therapy arm. So this study, and followed by a second one called the RESPONSE 2 study that addressed the same questions but in patients with less advanced disease, also was positive. So we have now 2 studies showing that ruxolitinib is efficient in PV patients who are resistant or intolerant of hydroxyurea. Ruxolitinib therapy is obviously not for every PV patient, and the current indication is as a second line after hydroxyurea. So certainly patients who are resistant or intolerant to hydroxyurea, but also to interferon alpha, because some patients are treated with first-line therapy with interferon alpha, may benefit from ruxolitinib. We have also the group of patients who have still a high symptom burden, especially pruritus. Some patients really have a very poor quality of life because of itching after the shower. They cannot even take a shower because of that. And ruxolitinib is very efficient on the symptoms of these patients. We also have patients who have a symptomatic splenomegaly. It's not a majority of patients, but some PV patients may experience an increase in spleen volume and also some symptoms linked to that, and ruxolitinib is good also for this. And maybe also patients who have a disease that is not well controlled with hydroxyurea, like for example those who still require phlebotomy to control their hematocrit, or those patients with elevated leukocytes. So these also are potential good populations who may benefit from ruxolitinib therapy.